So good afternoon, everyone, and welcome back to LaidBlack, a conversational series on race in medicine and medical education. Devin, do you mind keep letting people in?
Thank
you. So my name is Farrah-Amoy Fullerton. I'm a fourth-year medical student and an aspiring pediatrician, and I'll be your host and moderator for today's session on microaggressions, overt acts of racism, and their profound effects on the mental health of BIPOC students and residents. So I'd like to take a moment to thank everyone for coming to listen and to learn. I also want to take a moment to say rest in power to Congressman John Lewis and Reverend C.T. Vivian, who we lost yesterday, both extremely powerful voices in the civil rights movement. So join me as we take a moment of silence to honor those we lost yesterday and the many others we lost while fighting.
Farrah, I can't hear you.
So thank you guys for taking that moment with me. We have a variety of people from different backgrounds and clinical experiences, and as such, it's important to respect varying perspectives and speak in a way that is easily understood by others. The two main themes for every session of LaidBlack are growth and community. I intend for all voices to be heard equally in an effort to heal and grow as a society. If you'd like to keep up with the conversation, LaidBlack is on Twitter and Instagram at the handle @LaidBlackLive. And now that I've introduced myself and told you what LaidBlack is all about, I'm going to have my panelists introduce myself or himself. Devin, go ahead.
Hi, I'm Devin Gladys, a Pomona College alum and with an MS in molecular biology from UCLA. Me and Farrah are longtime friends. We've been friends since high school. Also, Farrah, when you were speaking, your mic was kind of going in and out, so I only caught about half of what you said.
Okay. Is everyone able to hear me a little bit better now? You can just do like a thumbs up or something. Seems like everyone's good. So let's move on to our guidelines for today. So for number one, panelists are going to be the ones to lead the discussion, and they're going to be speaking briefly after each side. And then after that, the audience will have a chance for commentary. So for number two, if an audience member would like to speak, please state your name and where you're from in the chat with a request to comment. This way we can keep track of the queue. For number three, feel free to use the emoticons during this session, but know that they will not be a way to request to speak. And for number four, I'll provide links to the LaidBlack mailing list and all social media handles so everyone has a chance to stay up to date. And these will be posted in the chat 1 minute right now. And at the end of the chat as well. So it seems I'm still going in and out.
Yes.
I just posted the links in the chat. And I will try to fix my microphone. Okay. So finally, LaidBlack is a space for constructive criticisms in the name of collective growth. Opinions will be tolerated as long as they're not harmful or derogatory in any way. With those rules established, let's begin with the presentation. And after we're done, we're going to finish with a video from Dr. Nadine Burke-Harris. So now I'm going to start sharing my screen and we can start the presentation. Ooh. Oh. All right. So again, What we're talking about today is microaggressions, overt acts of racism, and their profound effects on the mental health of BIPOC students and residents. So for anyone that is on Zoom right now and is able to access their poll, I'm going to start a question. The first question. Is it going to launch all of them at the same time? It is. Y'all can just answer the first question for now. So what do you think about microaggressions? And we have 3 choices for this. Microaggressions are a real social threat. Microaggression is a term for the sensitive, or I don't know what a microaggression is. So go ahead and put your responses in. Are y'all able to see the poll? If not, you guys can just put whatever you like in the chat. Okay, so it's making y'all do all 5 of them. I'm sorry. And the poll is completely anonymous, guys, so go for it. I want y'all to keep answering, but I'm just gonna go ahead with the presentation just for the sake of time. So we are talking about what exactly are microaggressions, right? And so if we look at this table, I like this, not table, but this graphic, because it has microaggressions, stereotypes, and implicit bias on a triangle. And it defines microaggressions as subtle verbal or nonverbal insults, indignities, or denigrating messages directed toward an individual due to their marginalized identity. And it's often committed by well-intentioned people who are unaware of the hidden messages conveyed or the impact of their statements. And there are multiple examples of this, and it can be classified in many different ways. We're gonna go through all of this, but I wanted to, present y'all with this question because I wanna be able to kind of look at it from multiple sides. And so, Devin, do you have anything to say about this slide?
Yeah, just that I feel like as a Black person in academia, you kind of run into all of these at some point, kind of every level. And it's a far more ubiquitous than a lot of people might imagine.
Right. Okay. And so all of the stereotypes, microaggressions, implicit bias, they kind of all work together to create a really hostile work environment for the people that are in it, especially people that are Black, Indigenous, people of color. And so what the other perspective I wanted to explore before I open it up to the audience for discussion is this perspective here. So while I was doing research, one of the articles mentioned that, some of the participants deny the concept of microaggressions even existed because it contributes to, well, it promotes oversensitivity and, political correctness. So PC culture is what they summarized it to. So before I show y'all some of the quotes that are kind of summarized in this statement, let me know your thoughts. Feel free to unmute yourself and talk about it. Is anyone in the chat asking to speak?
So I guess just for like some real world examples of things that people have like actually experienced, for me, when I was in college, I had an afro. My hair was a lot longer than it is now. I think Farrah remembers actually. And one of the things was, so it was my first time in California. I didn't know any of these people. And for like, well, the whole first semester of school, everyone was always touching my hair. It was just like people coming up without permission and like just touching my hair and like making comments on it, like, oh, I think you should cut it, stuff like that. Got to the point where eventually we had like whiteboards outside of our room, and I just like wrote a note and I was like, please don't touch my hair anymore. And it like took me getting to that point for people to like finally realize that I was extremely uncomfortable with it, even though I had voiced it multiple times before.
So I can also attest to the hair issue. It might be a little different because, you know, I don't have an afro, but I do have an extensive collection of wigs, and I do like to switch them out from time to time. And for some reason, it's always a spectacle when I show up and my hair looks a little different, because my face doesn't change, it's just my hair, right? So these are just things that you unburden Black students with that, you know, other students don't have to make space for mentally. So I'm gonna just exit out from this presentation for a little while, just to show y'all the comments from the Denial of Microaggressions. And I'm gonna read this out for anybody listening in. So the first one, excuse me, states, microaggressions are a way of perpetuating the culture of victimhood that plagues our society and polluting the mind of today's overprivileged faux social justice warrior youth. Right, so any comments on that?
Can you hear me?
Yeah.
Okay, hey. So this is Andres, and I guess like one thing that statements like that make me think about is it always feels to me like it's someone who has never had like their authority or power criticized in any way. And I think a lot about political correctness and how it's usually a term used for things like this, even though no one would ever argue about, you know, if someone were to say something to you that hurts you and you speak up and say, hey, like what you said to me, like, did it make me feel good? And this could be about something like completely different from race or ethnicity or all that. And people are usually pretty good about understanding that aspect. And so it's always interesting to me how this is basically that situation where someone is saying, hey, like what you said did not make me feel good. And it's not okay. And I'm asking you to please think about that and refrain from saying it in the future, which, I mean, to me, doesn't seem that hard to kind of hear that from someone and be like, okay, I hear you. I'm sorry. I'm going to do better. And so to me, it's more about it seems to always come from people in power who like don't want their authority questioned in any way.
Right, and I find it interesting that in situations like these, people always think that the victim is always going to be subjective. There's no way they can be unbiased about their own trauma and the trauma that happens to people like them. But who said that, you know, people in power are the ones that can maintain objectivity? So that was a big thing that I was thinking about. So moving on to the next comment, and we'll talk about this one too. Extremely sensitive individuals use this word to describe comments that intentionally or unintentionally offend their fragile egos because they have been accustomed to receiving participation trophies in Little League and subsequently have not developed the proper coping mechanisms when encountering someone who doesn't like them, disagrees with their views, or generally has an opinion different from their own. It's a major development in the so-called PC culture. Using words like microaggression enables the user to declare oneself victimized in an intellectual way. So I'll open that for discussion.
I guess, you know, this is Rob Rosencrantz. I guess one of the things I kind of find fascinating in the various ways that people push back against, you know, what Ibram Kendi calls racist abuse, but we're calling microaggressions, is you know, the assumption that these categories like participation trophies or social justice warriors exist, you know, that like, oh, well, we all know what people mean when they say that, but even, you know, like even accepting that such a thing is actually like an independent feature of reality is like, in a way, like kind of accepting fundamentally bigoted premises, you know, like I'm not sure that I do believe that participation trophies exist. I'm not sure that I know what a social justice warrior is outside of a particular rhetorical tradition, which is trying to undo, you know, labor towards equality. And so, you know, I think it's kind of interesting just as an aside to think about, like, on intervening, you know, in these kinds of circumstances, to ask someone, well, what is a social justice warrior? You know, what does that mean? Oh, that's a bad thing. You know, oh, okay, why is it bad? You know, to drill down into these categories, you know, that form the basis of denial, and see how really legitimate they actually are on inspection. Just kind of a thought about like the practicalities of dealing with these denials. And that's, you know, just my perspective as someone who's not subject to microaggressions, you know, about ways to dissect those denials, not necessarily about what's practical for a person experiencing them.
Thank you, Rob. And yeah, the thing about the Little League trophies, I mean, I never got any participation trophies. Devin, did you get any participation trophies? Right, like we have always had to work 2-3 times harder to get the same recognition. So this participation trophy, I think I don't know who that song to. So the last comment is very much like the last one. So I won't read it. We can go back to our presentation and we can move on. And so for the next slide, we're talking about the different categories of microaggressions. So they're subcategorized as microassaults, micro-insults, and micro-invalidations. And from the paper that I got these categories from, up to 95% of trainees reported that they had experienced at least one form of harassment or discrimination during their medical training. And so quickly, I'm going to talk about what all of these are, and then I'm going to read out the results from the poll, and then we're going to talk about what these assaults or microaggressions look like to you and what they've looked like to me, and how we as medical students and residents have worked past it. So microassaults are explicit physical, verbal, or nonverbal acts of racism or discrimination that communicate that the targeted party is of lesser worth. Micro-insults are messages that are insensitive and disparaging to a person's racial identity or background, such as implying that a racial minority did not earn that position. So this is really common for Black people in academia because, you know, affirmative action. People think that Black people are only in places of higher learning due to affirmative action, when in reality, white women are the biggest beneficiaries of affirmative action. So things that we need to address or involve in the conversation after this. Lastly, we talk about microinvalidations, which are behaviors that negate, neutralize, or deny the experiences of people of color. So an example they gave of this was racially insensitive comments such as, "I don't see color," and or "we are all the same." And you know, I put that this is actually a form of racial gaslighting. You are invalidating the experiences of someone that does not, you know, share the same lifestyle background as you, and you're making them question their reality. It's a form of psychological manipulation. So with that, I'm going to open it up to Devin and then the rest of our audience.
Yeah, so definitely, especially with the micro-invalidations, a lot of things that I've heard other people get is like, oh, like, how did that person even get into grad school? Or this probably isn't just for them. I don't see them completing it, stuff like that. Not my experience, but another, one of my colleagues at UCLA, in the lab he worked in, one of the postdocs actually mentioned that they only thought that he got a fellowship because he was Black. They're like, oh, well, like I applied to that too, and I didn't get it when I applied, so you like must have got it because you're Black. Things like that. And for some people, it just like, I'm sure like they don't think about it before they say it and they just let it go. But statements like that can be extremely impactful to the person they're targeted at. And I've seen like a lot of that at UCLA and at Pomona as well.
Anyone else?
Another thing I would definitely mention is that I feel a lot of programs, while overtly being very open to the idea of being inclusive and addressing these things, don't have really a system in place to do it. And one of the things that people definitely have to consider when this happens to them is reprisals. So like, how are people going to react? Will people even take them seriously? And so a lot of the conversation about microaggressions happens between students and isn't necessarily between like an administration, simply because the students, want to do anything to jeopardize their spot in the program or to seem like they're being difficult. George.
Yeah. Everybody can hear me, right? All right. So I think the one was called micro insults. This is kind of going back maybe a couple of years ago. I don't know if you guys remember that girl who she applied to like University of Texas and she didn't get in, and she was thinking, oh, the only reason I didn't get in is because these Black people who got in by affirmative action took my spot. And in reality, most of the time, it's kind of like the people whose parents donated significant amounts of money, they are the ones who took the spot, or like they reserved that spot. So it's not necessarily, oh yeah, like affirmative action is taking my spot. A lot of times it's actions of nepotism or actions of bribery, which, I mean, a lot of times they don't consider it bribery, which is kind of weird, but a good amount of people will donate like millions of dollars towards a school. And then after that, their kid just gets in. Their kid doesn't really have to do anything to like get through the school because they donated so much money. So it's not necessarily that the teachers can fail them because the school is saying, yeah, you can't fail them because they donated so much money and we're trying to keep that going. And I'm not in the medical field. I'm in software engineering. And one thing that a lot of software engineering companies have an issue with is hiring a diverse group of people, just because a lot of their hiring managers, whenever they're trying to think about hiring people of color or just Black people in general, they usually try and start with the question, do we want somebody Black or do we want somebody good? And that's one of the issues, because it's not necessarily like they're basically saying if they're Black, they're going to not be good, but we need to have Black people for diversity, even though you can have a good Black candidate. And that shouldn't be kind of like a controversial statement.
Yeah, just piggybacking off of that, and to go along with what Ali Hing sent in the chats, is that when people talk about affirmative action taking spots, what they don't often mention is that you still have to be qualified to get the spot, right? They're not giving these spots to people that don't meet the criteria for admittance. So it's not as if these students are somehow unworthy of being there. And I feel like that gets left off in the conversation a lot. And also legacy students. At a lot of colleges and universities, legacy students are offered preferred admission, and nobody looks at that as a negative, right?
Yes, these are all really good points. And I think there was a paper I saw floating around on Twitter. I think it was for Yale. Allie sent this for Stanford. No, yeah, this is for Stanford. The paper that I saw was for Yale, and it was saying that over 45% of white students were either legacy or got in because their parents paid a substantial amount of money. And when they looked at the standards for admissions, like less than half of them would have been admitted. So it's real interesting to see how this is how things go down in the background, but Black people are always the one that have to take the brunt of the jealousy and inadequacy, feelings of inadequacy. So I included this picture because, you know, these are, well, they're supposed to be representing clinicians or people on the medical team, and they're holding up signs with certain microaggressions that they have personally faced. We have a Black woman who comes first. She says, "Nurse, can you find me a doctor?" And I honestly still get this. Like, I really don't know what's not clicking for y'all, that Black people are not only nurses and janitors. In the middle, we have someone who seems to be of Asian descent, and she says, well, her sign says, "Do you speak English?" And I mean, I don't speak, my first language is not English, it's Patois, but it's very close to English. Could a person from the US go to Jamaica and speak with the native people? No. But I have gotten, "Do you speak English?" when people have heard me speaking Patois to my family. And it's very infuriating because, one, not only do y'all think, you know, this is our country, you should speak English, but two, it's not your country either. You came here on a boat and infected the people that did live here and stole their land. So it's just really interesting to me how that kind of is juxtaposed when we're talking about interactions like that one. And then the last one we have on here, are there any doctors from America here? So anyone who is an immigrant that has come to the United States has faced xenophobia, especially since 9/11. It got like way worse since then. And yeah, like people are really in there asking, are there any doctors from America here? But you know, what they're really asking, are there any white doctors here? Because a white doctor can walk in and have a non-American last name, they will still be fine with that. So anybody want to open up for comment? If not, I'll just go to the next slide because we have been on this one for a while.
I think with the "Do you speak English" one, I think it's kind of notable that the United States doesn't have an official language. Like a lot of different other countries have English as a language or French as an official language. And so in America, that's why if you drive over to different parts of the city, you can see billboards and signs in completely different languages. It's legal for them because we don't have an official language.
So I have two scenarios that I found in a paper from Dr. Wheeler, 12 tips for responding to microaggressions and avert discrimination. He was nice enough to send me this paper, so I just want to shout him out really quick. Thank you, Dr. Wheeler. In our first scenario, I will read this out loud. A Black female trainee, Dr. W, has cared for a male inpatient, Mr. A, for several days and has introduced herself as Dr. W multiple times. On rounds, when the team comes in, the patient asks her, "Nurse, can you get me another pillow?" So we're gonna stop right there. And I want y'all to tell me, what forms of microaggressions do you see? What kinds of bias do you see in a question, in a scenario like this? And then after we get that out of the way, we'll talk about ways to tackle it.
The fact that she's female already, I mean, that patient has, and it's a male patient, so that patient already has put that female doctor as if she is not worthy.
Right. So yeah, just like Ms. Jenna said, a lot of sexism is kind of intertwined in this message. Allah, she put in the chat that micro insult and micro invalidation, absolutely, because as the idea that only women are nurses came about when, you know, we were in the world wars, all the men went off to war, all the women had to stay home and work. Only job they couldn't find work in was like nursing, housewifery things. And since then, you know, America has had trouble letting go of the idea that anyone can be a nurse. And it's really impacted because nurse should not be an insult. But yet when you're doing it to somebody who has, you know, studied in med school for 4 years, done their residency, and is coming back, it is very, very disheartening. So we're going to go on to the next part of the scenario. If a member of the medical team noticed this, what are some things that should be said or done, if anything at all? And when I look at the poll, 83% of y'all said, yeah, you would step in, but 17% said no. So if anyone wants to talk about what answer they chose and why, that would be good. Don't be shy, y'all.
So for sure, I definitely think that a lot of times when people see things like this happening, or if this happens to you, a first response for a lot of people is to laugh it off, or to ignore it, just because in the interest of not causing tension. And I feel like now we are moving more towards a culture where people are encouraged to address things like this as they happen. Which is a great thing. But I definitely think there are a lot of people who are still hesitant about it.
And yeah, so yeah, we're going to talk a little bit more about these. Like, so just keep these scenarios in the back of your mind. Let's move on to the second one, and hopefully y'all feel more comfortable talking about this one. So let me read this out loud. A medical team comprised of a senior doctor, 2 junior doctors, and 2 medical students enters the room of a patient, Mr. S, admitted for an exacerbation of chronic obstructive pulmonary disease, or COPD. Mr. S, who identifies as white, continues to require supplemental oxygen despite completing treatment for the exacerbation. The team previously recommended that he use supplemental oxygen at home. However, he has declined home oxygen. So the junior doctor is talking to him, and the junior doctor says, Mr. S, your oxygen levels are still a bit low even after treatment. As we mentioned, given your COPD, your lungs would benefit from oxygen when you go home. And Mr. S replies, I already told you that I don't want it. So the senior doctor steps in and says, thanks. It's important that we hear that again, so please tell us why. And Mr. S replies, it's simple. I live in a bad part of town and there are blanks all over the place. If I go home with oxygen, these blanks will steal the tanks. And blanks is racial epithet of your choice. So, what do y'all think? So actually, when I read number 4, which is like, would you intervene in scenario 2, 83 said yes and 17% said no. So, you know, if y'all want to talk about your answer, go ahead. Okay, so let's just quickly do a raise of hands to see if you would have stepped in. Okay. Only 3 people? Okay. So I'm guessing a lot of the hesitation is that, this is a very tense situation and it's hard to figure out what to say, what would be deemed professional, what would be deemed appropriate in the situation. So let's see. Since no one wants to talk about it, we're just gonna move on.
I can talk.
Okay.
This is Grace. I think that this is like exactly the kind of training that I want from my medical school. Like, this feels like I absolutely want to say something, and I want to say the thing that is gonna make my team feel cared for and respected and valued, and I want to say the thing that's not gonna prohibit this patient from ultimately receiving the care. Like, I want the best outcome, and I personally don't feel trained at this point in my career to feel confident in knowing how to do that. And I think that's one of the things that's really frustrating, because these moments exist and they happen all the time, and it's really crazy that I'm in my 3rd year of medical training and I still don't feel confident to respond appropriately to this.
Right. Yeah, Grace, you brought up a lot of great points. And I think the reason why nobody knows and why everybody's so hesitant is because we're not taught. This experience is completely left out of our medical education. And with all this sudden interest in, increasing the ranks of Black students, how are you increasing the ranks of Black students when you're not even giving them a chance to be protected in their clinical setting, right? So quickly, I'm gonna talk about some tips, and these are from the same paper from Dr. Wheeler, and I think he offered a few really good tips. Before we get into that though, I'm gonna talk about the sources of these acts, and I did a poll on this because I really wanted to see if it would line up. So the most frequent abusers were faculty members at 45.2%. And so if I look down at my question at who was the source, teacher, professor, and attending is tied for 67% with classmates. So, and then 50% said they wanted a patient, it was a patient, a patient's family, a client, or client family. So it's a little worse. And it's kind of intersectional and systemic. So you're getting this from the patients you're supposed to be serving. You're getting this from the hospital staff you're supposed to be working with to take care of your patients. You're getting this from the attendings who are supposed to be teaching you how to be a great doctor. And there is no way students can be expected to flourish in an environment like this. And if we look in recent literature, Black students, they usually have lower standardized test scores and lower evaluations. And I really do think a big part of that is from bias from faculty members. Faculty members are not trained in how to properly grade Black students with acknowledging their other problems. We're most likely to have other social family problems going on, most likely to have jobs during med school. So things like that, all these things that tie in. And another thing I found really interesting about this paper is that these experiences occurred significantly highest in surgery and internal medicine. And I can say for myself, my worst medical education experiences were in both of these rotations. I got called the N-word in both of these rotations. Nothing happened when I got called the N-word in both of these rotations. So obviously, the lack of policy is really disheartening, because how can I be proud of a school that doesn't want to protect me when I go out to work, right? So who has anything to say about that? I know I was talking for a long time.
I see it as it's a lot of times just a big ethics issue, because like in this scenario too, like on one end you want to just say, oh, okay, well, since you feel like you're unsafe going home because these people live around your house and they're going to steal your oxygen tanks, you can go home and figure that out. But like that's one of the ethics issues, because you can't just say, the whole premise of kind of being in the medical field is to like help these patients. And so I think trying to get him to take them home, like aside from like in a protected manner, to say, no, we'll make sure that they get to your house, is kind of like validating the fact that he has these opinions, and that, you're kind of like reinforcing it. And so that just kind of like trickles down into everything else. It's kind of like you want to treat your patients, but protecting your staff and faculty members, students, and residents, like trying to do all that kind of is in a conflict of interest, just because you can't treat the patients with the same amount of respect if you're going to not disrespect your staff, and you can't not disrespect your staff by treating the patients with respect when they're being disrespectful.
George, you brought up some good points, because there's always been, with things like this, there's always been the thing brought up about professionalism and how to conduct yourself within these situations. But professionalism wasn't built for Black people, if we're being completely honest. Professionalism calls you to wear the right clothes, keep your hair straight, natural colors. It tells you not to be rude, even to the people who you are serving. And that's where I draw the line. I draw the line a lot of places with professionalism, but I draw the line with putting up with disrespect and harm from a patient at my own expense. How am I supposed to treat patients in the future if the patient I'm treating right now is beating me up mentally? Like, it just doesn't make any sense to me. What do y'all think? Because I personally think I'm not obligated to take care of anyone who is causing me harm or in any way, physically or mentally.
Yeah, Farrah-Amoy, this is Rob. I think this is a really great scenario that you chose, because it illustrates a few different dimensions of the way that racism ultimately always harms people's health. It harms the health of Black people when they experience it. That's something that I think everyone on this call, or podcast should find, transparently obvious. It hurts you as a healer, right? Because your mind is being taken away from the process of healing to the racist abuse you just received from the person you're trying to heal. And, actually the last person it harms, of course, this is a point that Jonathan Metzl made in Dying of Whiteness, is the patient who is denying oxygen with COPD because of a racist fantasy he has about being robbed for an oxygen tank. And, I think kind of one of the interesting implications of that is that it suggests that intervening on racist behaviors is actually an obligation of physicians for health, right? That by intervening, you actually produce health, a robust health that includes the mental health of healers and the health of patients themselves. No one is improved by racism. That's the W.E.B. Du Bois quote, "The wages of whiteness," right? People will suffer in extraordinary ways for that small amount of credibility to be in the club. And I think it's just a great circumstance you brought up there to illustrate that point.
I think Allah had something to say.
Yeah, hi. My name is Annette. For those of you who don't know me, I'm a third year at UAB School of Medicine, and I'm currently in Tuscaloosa for my rotations. And we've already been seeing a lot of these kinds of issues come up. And first, I just wanted to address the professionalism thing that you brought up, Farrah-Amoy. We recently actually had like a session on that in Tuscaloosa, and I actually posed that question of how do you respond, or how do you react to like an attending or a patient or someone who poses some kind of injustice towards you while still maintaining that professionalism. And the person who was leading that talk gave a very unsatisfying answer, which was basically a non-answer. And so I think that, kind of like what Grace was saying earlier, this is the issue, is we're never trained how to deal with these issues. And so the people who are more likely to experience these kinds of situations, like people of color, we're the ones who feel like we have to advocate for ourselves, and then it's not going to come across as professional. And so in a lot of ways, microaggressions, while people might think that we're being too sensitive or too emotional whenever these things are brought up, it's because they're so integrated into how people interact with each other that it kind of like, it starts making you doubt yourself, and it has all these other underlying issues, like people questioning your professionalism or your integrity or your ability to do the things that you're supposed to do for your profession and your career. And so I think that people who say those things are the people who aren't experiencing those things, and they don't understand how harmful they are, because in my experience, I've more internalized those types of beliefs. Like, I feel like I have to perfect my English, because when I do speak English and people think that I'm not from here, even though I was born here, they comment on the fact that my English is really good. And that's offensive, because I've been speaking it my entire life, but I feel like I can't make a single mistake, otherwise I don't belong here, or something like that. And also, just like in general, the way that we have to present ourselves becomes more important, because people are less likely to take you at face value. And so I think that a lot of people just don't understand those kinds of implications that microaggressions have on the way that we act. And that idea of victimhood is more something that's like, if someone does say something against you, you're automatically going to start assuming it's because of all these ways that you are different, even if in that particular case it wasn't true, but that's how you've been normalized to think. So there are a lot of different problems, and I think in certain specialties like surgery and internal medicine, those things are more accepted because of the types of people that they attract, particularly surgery. And that's kind of a problem, and it because it really does antagonize people of color from being part of those career paths, because they don't want to experience those types of things anymore. Sorry, that was a soapbox, but
no, that was really good. You made a lot of really good points. So why I really think a lot of the background to why people get so upset or call BIPOC students and residents unprofessional or too outspoken or something like that is because the American society conditions Black people and people of color to be, meek, docile, not cause any trouble, because we're supposed to be supposedly stay in our place. And so when we, get the courage to stand up for ourselves, it's automatically a problem, because no one thinks we're supposed to be able to do that, to stand up for ourselves. So I really do encourage BIPOC students to stand up for themselves. And I encourage anyone who wants to call themselves an ally to defend those students as well, because often when we do stand up for ourselves, we are undefended, and that kind of defeats the purpose, because then we got knocked back down on our feet. So let us move on to some of the tips I wanted to show y'all about managing these. And so, as I said before, these are tips from the paper about microaggressions. And the first tip was to establish a culture of openness and respect up front. So I'm going to read the introductory statement from a senior physician that they included in the paper. Oh my gosh, I'm so sorry. That they included in the paper for use by physicians in other workplaces. So I believe that to learn and care for patients to the best of our abilities, we all need to feel comfortable and supported in our work environments. I wish that expressions of bias never occurred. Unfortunately, they do. Patients and families may say things that reveal their biases, and sometimes I myself may be the source. I want to know when you are not feeling comfortable or supported. I hope you will teach me as I teach you. So I think there are a lot of good parts about this introductory statement, but I want y'all to tell me what your thoughts are on this statement.
For me, one of the things that jumps out to me is that they take responsibility for when they are responsible for showing their biases. And I think that's really important, especially in a classroom setting or a teaching setting, because I've TA'd for a few classes at UCLA. And one of the classes that I TA in had a noticeable lack of Black people, barely any people of color at all. But there were no Black people. And this is the first class I TA'd for, so I didn't understand why. It was like a class of like 100 people, no Black people, super weird to me. And I TA'd for that class with a different professor in a different quarter, and tons of Black people. And so I just like kind of outright asked the students, so like, do you guys know why that is? And it was because of the culture around the classroom, where the professor that I TA'd for previously wasn't necessarily antagonistic of like Black people and the people of color in the classroom, but it wasn't supportive in the way that they would have liked. They felt like that they couldn't ask questions, and if they didn't get something, the fault was shifted to them rather than to the classroom setting. Whereas in the other classroom, it was a new professor, so no one knew what his teaching style was and what it was going to be, so they were more willing to like try it out and see how it was. And ultimately, I think it was a better classroom environment. And I also think who the educators are is really important too. I had a lot of people, Black people, students from that class come up to me and be like, "You're the first Black TA I've ever had. I was so excited when I saw you were my TA." And just talk about like their comfortability with coming to office hours and asking me questions. And when they like, and the fact that I was willing to sit there and kind of like pound it out with them until they got it, that was like something that they felt like they didn't get in all aspects. Or even just like support when the teacher did say something that may have rubbed them the wrong way, just having me there to be like, "Hey, you said this during lecture, and I just want you to be aware that some people didn't like what you said." So I think the environment is really important. And I think acknowledging that you're not perfect, it also goes a long way.
Okay, so yeah, a lot of I did really like the point that he says, I myself might be the source, because that takes a lot, right? A lot of the times when Black people deal with people who, do microaggressions or perpetuate microaggressions, they do not believe that they are a part of the problem at all. So it takes a lot of pressure off of us to try and like make the case for this, because we're often having to make the case, and it's sickening. So moving on, I thought that was really nice, and I think it actually would work to be more welcoming. And then Allie just said, I appreciate how it acknowledges that biases occur and does not ignore it. Yes. I also appreciate how it promotes a culture of personal and professional growth by taking accountability and invites feedback, which encourages and empowers others to speak up. So yeah, that's really good too, because a lot of reasons why people don't speak up is because of the reprisal. So if you're saying upfront, hey, this is a learning environment, we're here to grow with each other, that kind of takes a lot of the pressure off for thinking, oh, I might be reprimanded for what I say. So let's move on to the next tip. So the next tip is to be prepared to recognize microaggressions and discrimination. And so because a lot of these actions are kind of pervasive, faculty has to be paying attention. They cannot just be paying attention when they want to anymore. You have to give medical students the attention they need and deserve. So they have to watch carefully for discriminatory comments and behaviors. And these microaggressions and discriminatory actions disproportionately affect trainees from underrepresented minority groups, including those related to race, ethnicity, gender, sexual orientation, and ability. And in another paper I read, no matter what your background is, things like this disproportionately affect women of any race, of any socio-economic background. So if you make sure that you pull out behaviors, the ones that are more pervasive, kind of acknowledge that. That does a lot for the people who feel offended in the room. So if we're taking it back to, well, he does another example here. So senior physician, possible observation during inpatient rounds. I felt uncomfortable when Mr. J spoke only to the men on our team. I wonder if anyone else noticed that. So I think this is really good, and I've also never seen anyone do it. So does anyone have any experiences with an attending saying something close to this and opened it up to discussion with the team? Because I feel like we all have the experiences when the attending asks us, did you notice that? But never is it something that's like worth talking about, if that makes sense. So Sylvie said, never. And Allah said, nope, but I have seen attendings talk mostly to the men on the team. Oh yeah, girl, that's a real big thing.
I did have one experience, this is Carolyn Tishik, by the way. I did have one experience where I was in a surgery clinic and the patient told a sexist joke. And it was super uncomfortable. And I think the attending in the room saw that it made me uncomfortable. And we walked out and he did address it just by saying, wow, what a creepy old man. And I was glad that there was some sort of addressing, but I wish that it could have been more of a teaching moment and more of a discussion. And it's sad to me that that was the only time that I feel like it was addressed, because there were so many times that things like that happened during my third year.
Exactly. And I feel like when stuff like that is addressed, it's only addressed at the surface level. Like we talk about it and then we move on. And it's never enough. It's never enough. And it feels kind of patronizing to the people who are offended, because like, you didn't even need to bring it up if this was all that you were going to do. So let's move on to the next tip. So this one was one of my favorites because it allows for reflection of the person doing the statement or saying the rude statement. So I'll read y'all the caption. Upon hearing an expression of bias, educators may choose to paraphrase the statement, which is a form of interrupting microaggressions, which is a way to fight them, and repeat it back to the patient. Repetition can aid understanding while exploring the patient's beliefs and opinions non-judgmentally. And it also provides patients with an opportunity to modify their statement. So if we go back to the first scenario where it's talking about, nurse, can you go get me a pillow? We could give the example that one of the senior doctors said, Mr. A, what I heard correct? Did you think that this was one of your nurses? So just giving them a chance to kind of defend themselves and explain like what they really meant by what they say. I think that's a really good option. What do y'all think?
Hey, this is Amy Hudson. I'm a fourth year medical student at Huntsville campus. I think that's a really good option. When I was on internal medicine, a few of my female attendings, I noticed that they often got comments like at the end of when we were about to leave the room, like, oh, like, can you grab my pillow, or like, could you bring me a sip of water? Not necessarily thinking that, they were a nurse, but I definitely never heard them make those kind of requests to like a male attending, and they would always be, you can definitely get that, but let me show you the nurse button, and she can do that. And so, she kind of reminded that patient of her role versus, the nurses. But I think that is another good way of handling that situation, the one that paper showcases.
Yeah, Amy, you made a good point, because I've noticed that too. Like, and it happens with me a lot. And I'm so nice that I'm like, yeah, sure, I'll grab it. But like when I really think about it, they're not asking my resident, who is a man, to do that stuff. They're asking me every single time. So I guess I just have to be a little bit more cognizant, you know, standing up for myself, saying no, but I can show you how to get it if you want to. And one important point I wanted to make before we move on from this tip is that when attendings see this behavior and instinctively get defensive, they either want to apologize about it to accommodate the behavior or laugh it off. It signals implicit acceptance of that behavior when the behavior really isn't acceptable. And what that signals to the people who are offended is that, you know, y'all don't really care if we are, you know, abused right in front of you, if you're just going to invalidate it at the same time. So let's move on to our next.
Farrah-Amoy?
Yeah.
Yeah, I think that was so important what you just said. And I just kind of want to dwell on it for a sec if I can.
Yeah.
It you know, one of the you know, great activists of the 80s and 90s was a man named Noel Ignatieff. And he had a line in one of his writings that said whiteness is a club. And his whole goal was to force people to publicly disown their membership in that club. He's actually the person who said treason to whiteness is loyalty to humanity. He's an amazing person. And, you know, that's what is happening in those clinic rooms is, you know, when a male attending or a white doctor laughs off a racist or a sexist comment, is they're staying in the club and the patient just co-opted them into it.
Mm-hmm.
And I think that, you know, that kind of raises the stakes a little bit to what we should perceive them as, you know, which is that these are opportunities to publicly disavow, you know, white supremacy and the patriarchy. So these strategies aren't just like helpful tips for how to get out of an awkward situation, you know, like the stakes are actually quite high indeed, because they mark the way that we choose to engage with, you know, fundamentally the racial and sexist order of our society. So I just think it's really important, you know, what you described about the feeling of being left.
Right, abandoned.
Yeah.
So that was a really good point, Rob. And Rachel said in the chat, had an attending ask me what school I went to. When I told him, he replied, "What sport did you play?" I'd never mentioned in any way that I played ball in college. So yeah, I get that question a lot because I'm tall and Black. And most people assume I play basketball. And I actually have a story about this. So for the people who don't know, UAB has an Olympics every year. And like we play sports against all the other students and we form teams and stuff. So it's really fun. I wanted to cook because I'm really good at cooking, and you know, cooking was my niche. It was my ministry. I was comfortable with it, and I did it. I didn't win, but we're not talking about that. What we are talking about is how my team wanted me to play basketball so bad because they were short someone, and I was like, y'all, I don't know how to play basketball. I can watch it, but outside of putting the ball in the net, I really don't know anything else. But they wanted me to do it. And, you know, as someone who was trying to fit in, you know, it was like the first year of med school. So I was just like, okay, fine. So I went out on that court. I mean, I didn't try that hard because I literally didn't even know what I was doing. Eventually, they just took me off the court because I was just standing and looking and watching people run back and forth. And they were like, why didn't you just tell us you didn't know how to play basketball? It's so interesting because I definitely did tell you guys that. So it's like, you know, listen to Black women because, you know, we're not a monolith. Not everybody knows how to play basketball. So thank you, Rachel, for that comment. So yeah, these aren't just, you know, nice tips to get out of an awkward situation. These are stuff that allies need to have in their toolkit to use. So with tip number 8, I thought this was really straightforward. Just use objective statements and, you know, say it like it is. So like we talked about in scenario 1, Mr. A, may I clarify something? This member of your care team is not your nurse. She's the doctor who has coordinated all of your care in the hospital for the last 3 days. And, you know, that's straight up. Like, this is not your nurse, this is your doctor, and maintain that relationship while you're here. Does anyone have anything to say about that? Sylvie, love that response. I do too.
I actually had this experience like last week where a patient called me a nurse, and my resident just immediately stepped in and was like, she's actually a medical student and she's going to be a doctor just like me. And I like cannot express how I don't think anyone had ever done that for me before. And it was just like such a good feeling to have someone step in, and it like made me feel so inspired to step in the future. And it was just like a very clear, like, this is what she actually is, you know, nothing fancy about it, very simple. And it was super effective and made me feel like absolutely a part of the team in the role that I have worked hard to be in. So, you know, I don't know, personal experience, I really liked a response like this.
And these actions are so small, but they're worth so much to us. And it's like, you can do this for free 99 and get so much productivity out of your medical students. But I just don't understand why that is not the standard. It's all right. So let's move on to the next tip, because that one was pretty straightforward. So basically debriefing with learners outside of the room. So yeah, it's great to like talk about that encounter, but that encounter looks different to every single person on the team. So it's really important that when y'all are done to go out, talk about it, make sure everybody's on the same page, make sure everybody's voice feels heard. So when we talk about scenario 2 about the man with COPD and his oxygen tank, a possible self-disclosure in a debrief conversation, you should probably say, when I heard the patient ask where you were from, I felt uncomfortable. Or how did others feel during the encounter? And so other things you need to do in these situations is not only give people the space to answer, feel comfortable to speak, but you also need to acknowledge what actually happened. So we know that many women physicians are treated differently because of their gender. What have your experiences been? So I like that, you know, they acknowledge that this is a problem, it's a common problem, you're not alone, and you can speak without worrying about being reprimanded. So go ahead. Did anyone have anything to say about this one? Okay, because the last one I had was just honestly implicit bias training. Train the people that you are entrusting your Black students with, because otherwise, you know, this, you know, really terrible environment is just going to continue, and you're going to continue to have Black students with terrible mental health outcomes. So the last thing that we were going to do before we watch the video with Dr. Nadine Burke-Harris, because we've talked a lot about the effects on mental health, what doing good things can do for a medical student or a resident. So when I was doing all the research, it was noted that a majority of the students in it did not report any of the abuse they faced. And there are a lot of reasons, and we talked about them a little bit in the chat here, but you know, inadequacy in student support, as only 1/3 of the respondents reported being previously informed of how to handle such incidents. So not only are we not told how to handle them, we don't even know where to go to report it. We don't know who to talk to. Like, there is literally no framework for this. So yeah, students may not have known how to manage such encounters or where to look for help. They have chosen to remain quiet for fear of aggravating the situation further or afraid of reprisal. And a lot of them gaslighted themselves and deemed their mistreatment not as serious to warrant any action. So what do y'all think about these?
I would actually also like to add, from my own personal, very recent experience with this, is that there's also the fact that, or the fear that there won't be an adequate response, or that the response will be extremely delayed. So I've had an issue that's been going on now for 3 weeks, and I thought I wasn't sure if it was a serious enough issue to like actually bring it up. And I'm not gonna go into details or anything, but it seems like such a small issue that needs like a very small like I thought it was a very quick fix, and it's been going on for 3 weeks now, and now I'm like, why did I even bring this up, you know? So I think that that's something that's also important to take into account. Like, people might be afraid of the response if it's negative, or they might be afraid that nothing is going to be done, and so now you just like wasted your time and maybe put yourself in a more negative light in these people's eyes.
Right. Yeah, that's a really good point, Alum, because I honestly have the same same thing I'm going through right now, and it's honestly pointless because I've been doing it for 3 weeks. There's really no point to it anymore. I'm just over it. So if we have nothing to say about this PowerPoint, I will just exit us out, and we will close out with Dr. Nadine Burke-Harris's video.
Ali want to speak?
Oh, sorry, go ahead.
Hey, I'm Allie. I'm a third-year med student as well at UAB. And something that I've realized working with other student leaders is the frustrations that I've been having with them. Because although we would like to think that these are student leaders, these are the people who are inactive. They're the ones who aren't sharing the information with the people who need it the most. So when students in their classes come to me and tell me about their experiences, it's really frustrating to hear that they've never heard of Report It until the racial justice town hall. They don't know, they've been going through med school not knowing that there's a means of a safety measure or a way to report it, or at least to know that we have a professional development office that if you need someone to speak to, we can help you. And I know that it's difficult because the biggest part is that unless there's accountability, what does reporting do? And that's why we feel so unheard, because when we report stuff, we don't know how it's followed up on. We don't know if people are actually having discussions about it, or they're just reading it and dismissing it, thinking that it's not a big deal. So I feel like personally, that's been my biggest frustration, is not even with admin itself, but with the student leaders in our school, because they're some people are creating a toxic environment for others. And these people don't feel like they should talk up, because when they do, they get these people talk very negatively about them to other people, and that's their reputation on the line. So they would rather not say anything at all. So I think the biggest thing in medicine, more than anything, needs to be a means of accountability. Right. And not to be afraid of being accountable, but to own up to it, grow from it, and move forward together. And I think that we're really missing that in medicine. No one wants to say, I messed up, I'm sorry, how can I grow to be a better person? How can we go on from here? And hopefully that's something that we can move forward to now that we're having these discussions, but I truly don't believe anything will come out of it unless there is a system of accountability, or else it's truly performative activism. And that's only hurting us more, truly, than not doing anything at all.
All right.
Did you want to follow that up? Okay. All right. Yeah, Ali, that was really good. Performative activism is a really big issue, and it's really hard being a UAB student and fighting for all the things that we're fighting for, and then barely seeing any results. What did y'all think of the email that was sent recently about the steps they're taking in their anti-racism initiatives? Ali said good, but no accountability mentioned. Exactly. So it's literally basically everything that Ali just said. It was very empty. Like it looked good, but there was no real action in there. And it was very disappointing because that email came, 3 weeks after our last racial forum? And this comes after they'd gotten proposals, action items, all this stuff from us that we've been working on for months, and we still have nothing. So it's very disappointing, and we hope to see that UABSOM does better in the future, because it really shouldn't take this long, if we're being honest. And so with that, if no one else has any closing comments, Rachel said they just repeated our complaints back to us in an email, which is basically what they did to us. Yeah. They could have just copied and pasted all them little action items and put it back in there. So it's really disappointing. I haven't found the word for this yet about my feelings towards this, but it's disheartening. I feel disrespected, and I feel very sad for the Black students that are gonna have to come after me. I wanted to take on all this work just so that they didn't have to do it. But it seems like, it's going to be a long time coming. And that's very sad to me. Anybody else? All right. I'm going to go ahead and play the video.
In the mid-90s, the CDC and Kaiser Permanente discovered an exposure that dramatically increased the risk for 7 out of 10 of the leading causes of death in the United States. In high doses, the immune system, hormonal systems, and even the way our DNA is read and transcribed. Folks who are exposed in very high doses have triple the lifetime risk of heart disease and lung cancer, and a 20-year difference in life expectancy. And yet doctors today are not trained in routine screening or treatment. Now, the exposure I'm talking about is not a pesticide or packaging chemical. It's childhood trauma. Okay, what kind of trauma am I talking about here? I'm not talking about failing a test or losing a basketball game. I am talking about threats that are so severe or pervasive that they literally get under our skin and change our physiology.
So I'm gonna take a pause right here. We're gonna continue the video, but what she just said, things that get under our skin and change our physiology. So this is what I have to say about, microaggressions being something used by people who just want to be victims. Like, these things have actual effects, palpable, measurable effects on the body, physiological and mental. So this is why I chose this video from Dr. Nadine Burke-Harris, is because she talks about childhood trauma, but we can look at racial trauma in the same way. I'm gonna let her continue to speak because she does it very eloquently.
Things like abuse or neglect, or growing up with a parent who struggles with mental illness or substance dependence. Now, for a long time, I viewed these things in the way I was trained to view them, either as a social problem, refer to social services, or as a mental health problem, refer to mental health services. And then something happened to make me rethink my entire approach. When I finished my residency, I wanted to go someplace where I felt really needed, someplace where I could make a difference. So I came to work for California Pacific Medical Center, one of the best private hospitals in Northern California. And together, we opened a clinic in Bayview, Hunters Point, one of the poorest, most underserved neighborhoods in San Francisco. Now, prior to that point, there had been only one pediatrician in all of Bayview to serve more than 10,000 children. So we hung a shingle and we were able to provide top quality care regardless of ability to pay. It was so cool. We targeted the typical health disparities: access to care, immunization rates, asthma hospitalization rates, and we hit all of our numbers. We felt very proud of ourselves. But then I started noticing a disturbing trend. A lot of kids were being referred to me for ADHD, or attention deficit hyperactivity disorder. But when I actually did a thorough history and physical, what I found was that for most of my patients, I couldn't make a diagnosis of ADHD. Most of the kids I was seeing had experienced such severe trauma that it felt like something else was going on. Somehow, I was missing something important. Now, before I did my residency, I did a master's degree in public health. And one of the things that they teach you in public health school is that if you're a doctor and you see 100 kids that all drink from the same well, and 98 of them develop diarrhea, you can go ahead and write that prescription for dose after dose after dose of antibiotics, or you can walk over and say, what the hell is in this well? So I began reading everything that I could get my hands on about how exposure to adversity affects the developing brains and bodies of children. And then one day, my colleague walked into my office and he said, Dr. Burke, have you seen this? In his hand was a copy of a research study called the Adverse Childhood Experiences Study. That day changed my clinical practice and ultimately my career. The Adverse Childhood Experiences Study is something that everybody needs to know about. It was done by Dr. Vince Felitti at Kaiser and Dr. Bob Onda at the CDC, and together they asked 17,500 adults about their history of exposure to what they called adverse childhood experiences, or ACEs. Those include physical, emotional, or sexual abuse, physical or emotional neglect, parental mental illness, substance dependence, incarceration, parental separation or divorce, or domestic violence. For every yes, you would get a point on your ACE score. And then what they did was they correlated these ACE scores against health outcomes. What they found was striking. Two things. Number one, ACEs are incredibly common. 67% of the population had at least one ACE, and 12.6%, 1 in 8, had 4 or more ACEs. The second thing that they found was that there was a dose-response relationship between ACEs and health outcomes. The higher your ACE score, the worse your health outcomes. For a person with an ACE score of 4 or more, their relative risk of chronic obstructive pulmonary disease was 2.5 times that of someone with an ACE score of 0. For hepatitis, it was also 2.5 times. For depression, it was 4.5 times. For suicidality, it was 12 times. A person with an ACE score of 7.
So I'm gonna stop it right there really quick, and we're just gonna discuss what she just said. So across the board, there are multiple disease processes that you are put at higher risk for if you have an adverse childhood event. They actually did another study on this as far as like the effects of racism and what those can cause. And it was pretty much just the same: depression, anxiety, headaches, a whole plethora of things that, you know, with increased exposure to acts of racism, you get more and more exposed to. And so the pathophysiology behind this, and she goes in a little bit about that, is that you, with each event, you have repeated activation of your fight or flight response. And what that does, it gets your blood pumping, it gets your, so there's blood going to your muscles so they can contract, your eyes, they kind of contract, your throat kind of closes up, like your body's priming up because it senses an unmitigated social threat, right? And so this happens every single time a Black person faces an act of racism. And what's interesting about that is Black people can be experiencing multiple forms of racism at the same time. So systemic, interpersonal, institutional, all at once. And so it all kind of compounds and results in these terrible health outcomes that we see increased incidence of in Black and Brown communities. So does anyone have any closing thoughts for that? Yeah, go ahead.
Yeah, so I've actually had the pleasure of seeing Dr. Nadine Burke speak in person, asking her questions. And when I saw her speak about ACE scores and whatnot, someone in the audience asked if there had been any research done on epigenetic regulation as it relates to ACE scores, which is just a really interesting question, because when you are in a constant state of stress, when you're constantly activating this response, it seems natural that epigenetic changes would occur, change, you know, what genes are activated and what aren't, in return to stress and how we respond to it. And so there is research looking into that that hasn't been fully developed yet. But yeah, it's just really interesting. She also does a lot of great work in Oakland, where she's taking this information and kind of applied it in a real world context, where she's meeting with these patients, these young patients who have these high ACE scores, and the way she's treating them isn't just medically, right? She's bringing in the families of these individuals that have undergone trauma, and she's like helping them to find counseling as well. And so she's addressing it from multiple different points. Yeah. Farrah, you're muted.
Yeah. So when we talk about, racial trauma, it needs to be, said that racial trauma isn't just someone calling you a slur or using a microaggression. It can be you literally picking up your phone and watching a video of yet another Black man getting shot by police. That is racial trauma in itself. And so, it comes in many forms, and that it does play into, you experiencing multiple forms of racism at the same time. One of my biggest examples of that is that I came back to family medicine 2 weeks early, so I started on June 15th. And when I pulled up right in front of the family medicine clinic, I was really excited. I was happy. I was like, yes, finally going back to clinic after 3 months of being gone. So I opened my phone and I just scroll down Twitter just because I want a little laugh. And I scroll down and I see that someone named Oluwatoyin Salau was found dead. And I don't know, I stopped and I opened the article. I knew I shouldn't have, but I opened it anyway. And I read the whole thing. And it was very tough because I was so hurt by that story, just with how much I recognize with Oluwatoyin, that I really had to just take a moment and sit in my car and just cry because I was so hurt. And I was upset because I was like, dang, now I got to go to work on my first day of family medicine and prove myself while I'm still grieving over Oluwatoyin. So, you're expected to be so professional in these settings, but to be professional is to deny an entire part of my identity that is it's integral to my identity, and it's affecting me daily. So, those are my thoughts on professionalism, the multiple forms of racism we experience simultaneously, and how it affects our mental health going in. Allah, she said that my psychiatry attending has said that patients are just coming in and looking for meds, so it's easier to just give it to them, even if they could be helped in other ways. So yeah, so this is talking about, just how different things are with COVID-19. I think this might be Allah's mentor, but one of the people here in UAB, they're doing research on how telemedicine, how Black patients using telemedicine still don't get the help they need, and aren't getting the medications they need just because they can't afford the in-person visit. And, doctors are more likely to keep telemedicine health visits short and on the surface. So it's very systemic. It reaches all parts of this. Does anyone else have any closing statements? Anyone in the chats? No, I think that's really it. So I'm gonna stop sharing my screen and all right, so we're gonna finish up. So I'm gonna post the links I posted earlier as well. And the very last link on this is the Harvard Implicit Bias Test. And a lot of people left, but hopefully I'm gonna get this out in the email and the mailing list. But the Harvard Implicit Bias Test, you can take it yourself and see what kind of biases you yourself carry. And that can be really helpful in someone who's a new ally, trying to start out, identify their biases so they can work on them. So I really think you guys should check that link out. I also have the mailing list here, so y'all will know when my next LaidBlack session is, because unfortunately this will be the last one for at least a month. I have to study for my boards, so I cannot, keep doing this weekly. But when we come back, it'll be better than ever, and I look forward to seeing y'all at that time. If there are no questions, thank y'all for coming, and I'll see y'all when I see y'all. Thank you.
Thanks for having me, Farrah-Amoy.
Yeah.